Welcome to our webinar titled COVID-19 Update for MDS MPN Patients. This is a critical topic for all of you, and the Aplastic Anemia and MDS International Foundation has always been here to support our patients and families for the past 36 years. Thank you for joining us. My name is Alice Hauk, Senior Director of Health Professional Programs at AAMDSIF, and I'll be moderating the presentation today. As we get started, we recognize the generosity of Bristol-Myers Squibb and Acceleron for special support of our COVID-19 educational programs. We also acknowledge Bristol-Myers Squibb, Alexion Pharmaceuticals, Apellis, Jazz Pharmaceuticals, Agios, Genentech, and Takeda for their financial support of our 2020 webinar programming and the generous support of patients, families, and caregivers like you. Today's specialist is Dr. Ruben Mesa. Dr. Mesa is the director of UT Health San Antonio MD Anderson Cancer Center. Dr. Mesa's practice builds on his role as an international expert on myeloproliferative neoplasms, or MPNs, a group of bone marrow disorders that often lead to leukemia. He is a fellow of the American College of Physicians and is certified by the American Board of Internal Medicine in Hematology and Medical Oncology.
But obviously, this webinar is quite a bit more complicated than normal, given the tremendous impact that we've had regarding the COVID-19 pandemic that has complicated life for all of us, not only in the United States, but around the world. And it has increased it further for those individuals that have difficult diseases, underlying medical problems, and it has been shown that individuals that have blood diseases, particular blood cancers like MPNs, like MDS, may have higher risks. So I wanted to take a few moments to share with you just some of the highlights of some of the discussion that's been going on that is relevant for this group, and then leave some time for questions both regarding MPN, MDS, therapies for these patients, but also issues related to COVID as it relates to this piece. So first, the risk of COVID-19. First, COVID-19 is actually the name of the syndrome. The virus that is infecting people is the coronavirus. Corona is just a Latin word meaning crown, and that's just a bit of a description that the virus itself looks a bit like a crown under intense microscopes. Now, why this has been such a problem are a couple key things. First, it has been a very contagious virus, more contagious than most. Second, is that a percentage of the people that become infected, fortunately the minority, but still way too many, develop a very severe pneumonia from the infection. A pneumonia means infection in the lungs, and fluid builds up in the lungs, but the lungs become very inflamed. And the reason that that is a problem is, of course, our lungs are where oxygen is exchanged from the air into our bloodstream. So when the lungs are inflamed, it interferes with oxygen getting into the bloodstream. So people need mechanical ventilators or other things to intervene to try to get enough oxygen into the blood to sustain life. That's where there's been all the discussion of intensive care units, ventilators, things of this nature. Now, patients with chronic blood conditions, are they at greater risk? Again, like the spectrum that I showed you, it probably exists on a spectrum. So other things independent of the blood are important. Is it a younger individual or an older individual? Have they been active and fit, or have they been debilitated and severely affected by their disease or other diseases? Do they have heart disease? Do they have lung disease? Are they of advanced age and have debilitation from that? So all of those are factors. In terms of the blood, how debilitated are they? Are they needing transfusions? Is their white blood cell count low or severely low to increase the risk of acquiring infection? We've been in close contact with our colleagues in Wuhan, China, in Asia, in Europe, particularly in Northern Italy, France, the UK, and of course here in the US, both in very highly affected areas like New York and others. And we do have concerns regarding higher risk for patients with blood diseases, but it is again quite individualized with other aspects of your health, your medications, all being factors in terms of what that risk looks like. We know during this time that it's important to stay in close contact with your physicians and your healthcare team. And frequently that has been occurring during this time through electronic visits, as well as other complementary ways to understand your risk and to understand whether there should be any change in the therapy that you're on. In general, we've been trying to lead people on their current approach in terms of therapy, because those therapies are important. And we fear that stopping any therapy that patients are on might actually have the underlying condition worsen and might ironically put them at greater risk. Additionally, we know that there is perhaps an increased risk of blood clots, severe blood clots such as stroke occurring in individuals that have been infected with the COVID virus. As you might imagine, patients with MPNs that I had already mentioned have a risk of blood clots. We are concerned that they are at greater risk. We do not know that for certain. The information is continuing to evolve in a very rapid way for these patients. But that is at least a concern, and we are trying to be mindful of being aggressive in controlling the counts where appropriate for these individuals. Additionally, patients that have been affected by COVID, there are some of them that are put on protective anticoagulants at this time to try to prevent complications from occurring. Now, what about testing? The current time, the availability of testing is rapidly increasing across the United States. And let me say that there's testing really at two levels. First, there's the testing, do you have the virus at the current time or not? And now there have been multiple FDA approved tests that individuals can have, and we'll get around to in a moment whether that is necessary. And then second, the testing that still is really being developed in terms of immunity, meaning have you already been infected and have antibodies in the blood? So first, testing to see whether you have the virus. At the current time, the testing has primarily been done in individuals that are symptomatic, and we have concerns that they are infected. There has been relatively limited testing of individuals who are asymptomatic, don't have any symptoms of the COVID infection. Increasingly, we are testing people that are asymptomatic if we think it's important to catch the infection early. So at our cancer center, we have evolved now with broader availability of testing. We do test people who are receiving chemotherapy or starting radiation therapy or going to have a medical procedure or going to have a surgery or going to be admitted to the hospital. But we're not testing everyone. We're testing those individuals that we think are going to have something medically done that it would be good for us to know if they had the infection, because it may suggest to us that we delay doing that medical intervention until the infection has resolved. Now, regarding the testing of antibodies, at the current time, there's a few key things that we don't quite yet know. If we have antibodies, does that protect us against having the infection? And if so, for how long? So at the current time, one, they're trying to develop tests to be certain that if you test positive for having antibodies, that it's specific for the COVID-19 infection. The reason for that is that there are other coronaviruses, such as a cold virus, that we might encounter. And if we had a false positive, meaning we said that you were immune and you were not, and people viewed that as a way to separate if they're protected, it would not serve anyone. So the testing in terms of antibodies is a work in progress. Next, what about treatment? So at the current time, it has been a difficult virus for us to treat. There's a newly approved therapy called remdesivir, which is an antiviral therapy that actually was used against Ebola. And this is an IV drug, powerful drug, that has been used and is now being used in people who are in the hospital already very sick with a COVID infection. This would not be a therapy that someone who was at home that had the virus, who was not overly ill, would necessarily receive. There's multiple antiviral therapies that are being tested and ongoing. There's other therapies you've heard about on the news, some of which the results have been mixed, or other therapies like hydroxychloroquine, that the results have not been favorable thus far. But all of these are clinical trials which are ongoing that are being studied in a tremendously rapid fashion. Additionally, there are therapies that are being investigated to try to stop the inflammatory pneumonia or to improve it. So the medicine that I had mentioned, ruxolitinib, and potentially the other JAK inhibitors, can help to block inflammation. And there have been some benefits of use of ruxolitinib in people who were severely sick with COVID on ventilators. And now there is a clinical trial looking at it in those patients. Independent of the issues of MPNs or MDS, just using it for its own parts. Now, what about getting healthcare during this time? I think the key is, the current period that we're in, which is slowly evolving away from the peak, means that there is not going to be a period without a risk in our society for the immediate future until we have a vaccine, which hopefully will be sooner rather than later. No one truly knows when, but I know every effort is being done to find an effective vaccine and have it be broadly available. But during the current time, it's important for you to continue on with your healthcare. Individuals that have these diseases, these are difficult diseases, and they are ones that we really cannot ignore for an extended period of time. Maybe individuals have delayed or canceled appointments in March or April in the hopes that they could then have those appointments in May or at latest June. We realize that there is no endpoint in the immediate future, so important that you be connecting closely with your healthcare providers, whether that be a face-to-face visit or through an e-visit. During this time, if you have severe healthcare needs, chest pain, shortness of breath, blood in the stool, anything acute, get urgent medical care. You can now, perhaps at the beginning of this crisis, there was a lack of gowns and there was real risks in going in for medical care. Now, I'd say across the US, healthcare systems have been much better stocked, and you clearly can go into an emergency room or a doctor's office in a safe way. If it is not urgent, you can certainly connect with your physician first in terms of how best to get assessed. Most of them, if what you are concerned is whether or not you have the COVID infection, if it is not severe, meaning you're not having acute shortness of breath, chest pain, most of them will have you tested in a way through a drive-through test or another, so that you're not necessarily coming into the ER to be assessed for the COVID infection. We're approaching it that way to try to decrease the risk of people sharing amongst them. Now, what about impacts on treatment? Well, when March and the beginning of April rolled around and we had thought that the period of greatest risk was going to be very short, a lot of treatments were put on hold. I think we have evolved quickly away from that, fearing that holding treatments would be harmful to patients, and knowing that there's not an immediate endpoint that dramatically changes the risk in society now in May or the beginning of June. So I think the question now is, how do we proceed forward in the best and the safest way that we can? And part of that is trying to keep our medical environments safe. So for example, at our cancer center, probably similar processes to many other cancer centers, as I'm in discussions with others, we screen people at the door for fever, with symptoms. People get a sticker, just like this sticker I got here today. I get screened like everyone else, with a temperature, with questions. I wear a mask. I'm in my office alone, which is why I'm not wearing a mask, but otherwise would be wearing a mask, having all of the surfaces closely cleaned, keeping individuals socially distant if they are in waiting rooms. In other areas, such as those awaiting treatment, in infusion, or for radiation therapy, we actually have them wait in their cars, and then we text them so that they can come directly in for treatment. The final, as it relates to these diseases, is the issue of stem cell transplant, or allogeneic stem cell transplant, cells from someone else. These individuals, their immune system is tremendously compromised during the process of undergoing a stem cell transplant. So at first, there had been a bit of a hold on proceeding with these transplants during the peak of this crisis, but now as we're evolving out, that is an active discussion between yourself and your transplant physician, but likely to be moving forward, trying to have that be as safe as one possibly can be. Those individuals that are stem cell transplant survivors should already be in close contact with their healthcare team regarding how to keep safe during this time. Indeed, I'll conclude by saying, this is an infection that none of us want to have. And although there's certain groups of people that we fear have a higher risk, we realize that is anyone can become severely sick from this or potentially spread it to others. So patients with chronic blood diseases, such as yourselves who are on this call, best to be prudent during this time, follow your local advice quite rigorously, use masks when in public for the time being, keep socially distant, and remember the primary way that people acquire this infection is they touch something and then they touch their face, meaning the eyes, the nose, the mouth, as ways that the virus can get into your body. It does not get into the body through hands. So people ask, well, should I wear gloves? It's not been found that gloves are particularly helpful because you can have the virus on your gloves just the same as your hands. And sometimes people incorrectly feel that they're more protected with gloves and are more likely to be touching their face. So really frequent hand washing, realizing that your hands are the primary way that virus is likely going to get into your body through your eyes, nose, or mouth. It's an awkward thing to get used to, but it's crucial doing that out in public. So a bit of a high-level overview on MPN and MDS, and a deeper dive in issues.
Thank you, Dr. Mesa, for sharing your time and expertise with us, especially during this very challenging time. AAMDSIF will continue to provide timely updates about COVID-19 and answer your questions as quickly as possible. If you need more information, you can contact us in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question or inquiry on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 36 years. This concludes today's program.